Good day, dear students. I'm glad to see you. Today, we continue the course of pediatric infectious diseases with the study of acute respiratory diseases. Let's define what it is. According to International Classification of Diseases 10, acute respiratory infections is classified based on the site of infection as acute upper respiratory infections and lower respiratory infections. Acute respiratory infections, presence of cold or cough, with or without fever, rapid or difficult breathing. The critical respiratory rate in children under 2 months of age is 60 per minute. 2 to 12 months, 50 per minute. Viral infection causes acute respiratory disease in children in the 3 days in 19% of cases, and bacterial infection up to 45% of cases. At a later date, chlamydia 7% and mycoplasma about 15%. This slide shows the difference in the number of types of different pathogens found in swabs taken from the oral mucosa. Swabs were taken from healthy children with acute respiratory infections and patients with pneumonia. On this slide, we see the following pathogens, such as coronaviruses, rhinoviruses, adenoviruses, enteroviruses, and others. Now, let's return to the study of respiratory tract infections, recall the anatomy and topical diagnosis. Topical diagnosis corresponds to the level of respiratory system damage, rhinitis, pharyngitis, tonsillitis, and other. This slide presents the rules for making a diagnosis by type according to clinical classification, respiratory tract injury, a form of gravity, complications. Here, for example, is how it is customary to write a diagnosis in the Russian School of Infectious Diseases. Acute respiratory infections, adenovirus infections, acute tonsillopharyngitis, moderate severity, uncomplicated. Now let's talk about the rule of examination and taking the history. Taking the history generally should start with the presenting complaint. Why did you bring the child? This includes the personal history, family and social. Observe as many signs as possible before touching the child. These include is the child alert, interested and looking about? Does the child appear drowsy? Is the child irritable? Is the child vomiting? Is the child cyanosed or pale? Are there signs of respiratory distress? Does the child use axillary muscles? Is the lower chest wall indrawing? Does the child appear to breathe fast? Count the respiratory rate. First, we examine the baby in order to detect a possible rash. There may be a varied rash on the face, trunk, and limbs. Then we palpate the lymph nodes. How to palpate lymph nodes? Do the exam with free fingers of your dominant hand. Use your free middle fingers to feel for lymph nodes. Do not use your thumb, which is less sensitive. Feel with the pads of your fingers where your fingerprints are. Do not forget to describe the size of the lymph nodes. About instrumental examination. Instrumental examination, which can be checked by a pediatrician, includes direct pharyngoscopy, rhinoscopy, and otoscopy. The main inspection tool is the otoscope. With an otoscope, you can examine the oral cavity, nose, and ears. Please look at these two slides. Please note, in the picture on the left, the doctor is not using a medical flashlight. This is wrong. Be sure to use a light source. Inspection is carried out with a spatula. And this is an anterior rhinoscopy procedure. We use funnels to examine the nasal cavity. With the help of rhinoscopy, a swelling in the nose, a foreign body, and also purulent discharge are clearly visible. Otoscopy is carried out according to certain rules, which are described in the course of otorhinolaryngology. For those who wish, you can find a lot of training videos on YouTube. Every pediatrician and therapist should not only be able to do this procedure, but also be able to evaluate it, what he saw. About tonsillopharyngitis. Infectious causes of acute tonsillitis in children are presented in this table. I propose to remember the following. In children under 3 years old, all tonsillitis are usually viral. The causative agent of a real bacterial tonsillitis is group A, beta streptococcus, which does not occur in children at this age, so they do not have a real tonsillitis. The slide shows the mucous membrane that we can see with acute respiratory infections, an antenna for enterovirus infections, for example, oral candidiasis, aphthous ulcers, and, for example, streptococcal tonsillopharyngitis. About treatment of viral tonsillitis. It is recommended to drink warm using lozenges containing antiseptics to eliminate cough in case of pharyngitis, which is associated with sore throat. It should be noted separately that many children with pharyngitis tolerate cold drinks much easier. Cold liquids and food will in no way worsen the disease. In all clinical guidelines, the red line is the recommendation: drink cold beverages. This slide shows An endoscopic picture. On the left, normal tympanic membrane, and on the right, with otitis. About the treatment of acute otitis media and prescribing of antibiotics. The criterion for prescribing antibiotics for acute otitis media in children is age. Children of the first 6 months of life, an antibacterial drug for otitis media is prescribed even if the diagnosis is doubtful. 6 months to 2 years. An antibiotic is prescribed to all children in whom the diagnosis is obvious. And in case of a doubtful diagnosis, antibiotic therapy is used in severe cases. In other situations, observation is included for 48-72 hours. Laboratory markers of bacterial infection is leukocytosis, more than 10,000 cells, shift blood formula to the left, C-reactive protein, more than 30 milligram, and procalcitonin, more than 2 nanogram. These levels cannot be considered an absolute measure of bacterial infection. We can talk about a high probability of a bacterial infection. Now we will move on the description of diseases such as influenza, parainfluenza, adenovirus infection, and respiratory syncytial infection. Basic symptom of influenza. The incubation period is short, from several hours to days. Onset is acute without prodromal phenomena, dry catarrh, intoxication, febrile temperature. The main symptoms of parainfluenza: lack of severe intoxication, dry catarrh. A typical complication is false croup. Croup is a clinical syndrome that develops in patients with inflammatory changes in the larynx and is accompanied by hoarseness or backing cough and shortness of breath, stenotic. The clinical picture of parainfluenza is presented by croup syndrome, difficulty breathing, inhalation caused by laryngeal edema. Acute viral croup develops mainly in young children, the first 2 years of life. At an older age, croup is rare and no longer has a viral nature, but an allergic one. The tendency of children in the first years of life to develop croup syndrome is associated with the anatomical and physiological features of the structure of the larynx. It is narrow, the cartilage is soft, so the edema develops quickly and creates a significant obstacle to the inhaled air. Dyspnea with stenosis is always inspiratory. Now I suggest you to watch the video with the baby who has viral croup. There are three stages of acute stenosis. The first, compensated, when there is only a rough back-end cough. There is no shortness of breath in the intervals between coughing attacks, and there are few of them. The child's condition is not disturbed. The second stage, shortness of breath, is expressed. Breathing is noisy. The retraction of the intercostal space is visible. The abdominal muscles are involved are breathing. And the third stage, decompensated. Respiratory syncytial infection is an acute viral disease caused by the respiratory syncytial virus, transmitted by airborne droplets, characterized by lesion of small bronchi, bronchiolitis in young children. In the clinical picture, the temperature is not high. Unlike stenosis, there is no breaking cough. Adenovirus infection is characterized by a gradual onset, low fever, and severe catarrhal symptoms, severe runny nose, conjunctivitis, wet cough, moderate sore throat, viral tonsillitis. In addition, adenovirus infection is characterized by an increase in the cervical group of lymph nodes and sometimes an increase in the liver, as well as a spotted rash. Now let's talk about the main features of clinical picture of acute respiratory infection in children of the first year of life. The main difference is that they never have a typical clinical picture. The temperature is low, up to 37.5. There is no cough, runny nose. There may be difficulty in nasal breathing. Often children become restless, sleep poorly, cry. Digestive disorders often develop regurgitation, bloating, and loose stools, making diagnosis difficult. Laboratory diagnostic in outpatient practice looks modest, since most methods are not available. Serological diagnostics is almost never used, only for coronavirus infection. The most common method is the oral swab polymerase chain reaction, which detected RNA and DNA of respiratory viruses. Treatment of respiratory infection consists of three main components: drinking plenty of fruits, antiviral drugs for influenza and syndromic therapy, antitussive, antipyretic, and other. One of the basic rules for the treatment of acute respiratory infections is a ban on the prescription of antibiotics in the first days of the disease. The main antiviral in flu is the oseltamivir, Tamiflu. From syndrome therapy, we will dwell a little on the rules for the use of antipyretic drugs in children and inhalation therapy. Antipyretic drugs in children are assigned at a temperature above 38.5, and if the child has a history of febrile seizures already at 37.5. There are two main drugs, paracetamol and ibuprofen, which must be calculated per kilogram of weight. During the day, the child can be given antipyretic medicine no more than 5 times. That is with an interval of 6 hours. Usually, antipyretic drugs are prescribed by mouth, but in case of a particularly high fever or when drugs are ineffective by mouth, parenteral administration is used. Usually, these are two drugs, chloramine and metamizole sodium dipyron. Dosages for administration 0.1 of each drug for 1 year of life. In viral croup or bronchiolitis, treatment usually begin with inhalation therapy through a nebulizer. 3 milliliters of saline is poured into a nebulizer cup and budesonide is added, usually 0.25 milligram. No more than 2 such inhalation can be done per day. Inhalation is continued for 20 minutes until a cloud of steam forms. Antibiotics for acute respiratory infection are prescribed in certain cases with the development of complications, otitis media, pneumonia. Ampicillin derivatives are recommended as first-line drugs. Prevention of respiratory infections as influenza can be non-specific and specific vaccination. CDC recommends use of any licensed age-appropriate influenza vaccine during the 2020 influenza season. There are different types of vaccine available in India as described in the immunization guideline. For example, this slide. Students, move on. Now we will talk about chickenpox. Chickenpox varicella is caused by the varicella zoster virus. The disease is generally regarded as a mild, self-limiting viral illness with occasional complications. Varicella is common and highly contagious and affects nearly all susceptible children before adolescence. Although most varicella infection confers lifelong immunity, varicella clinical reinfections among healthy children have been described. Chickenpox is usually a benign disease in children, and almost all children recover uneventfully. However, varicella is not totally benign even today. A significant number of varicella cases are associated with complications, among the most serious of which are varicella pneumonia and encephalitis. Presenting symptoms may include a history of low-grade fever, abdominal pain, a history of rash, intense pruritus, headache, malaise, anorexia, cough and coryza, and sore throat. Rash and fever are the typical finding during physical examination in pediatric patients with varicella. About pathophysiology. The causative organism varicella-zoster virus is a member of the human herpes virus subfamily. Alpha herpes virinae, and like all herpes virus, is a DNA virus. The virus enters through the respiratory system and colonizes the upper respiratory tract. Viral replication takes place in regional lymph nodes over the next 4 days. 4 to 6 days later, a primary viremia spreads the virus to reticuloendothelial cells in the spleen, liver, and elsewhere. After a week, a secondary viremia disseminates the virus to the viscera and skin, eliciting the typical skin lesions. The pleomorphic rash characteristic of varicella: papules, vesicles, and pustules are concretely present. The usual incubation period is 10 to 21 days. The patient is contagious from 1 to 2 days before the appearance of rash until the lesions crust over, usually 5 to 6 days after the rash first appears. Varicella is associated with humoral and cell-mediated immune responses. These responses induce lasting immunity. Repeat subclinical infection can occur in these persons, but second attacks of chickenpox are extremely rare in incompetent persons. About etiology. Varicella is caused by the varicella-zoster virus. The infectious particles are cell-free virus particles derived from skin lesions or the respiratory tract. Transmission occurs mainly through respiratory droplets that contain the virus, making the diagnosis highly contagious even before the rash appears. Direct person-to-person contact with lesions also spreads the virus. In addition, maternal varicella with viremia can transplacentally spread to the fetus. This leads to neonatal varicella. Risk factor for severe varicella is neonate are as follows. The first month of life, a neonate's first month of life is a susceptible period for severe varicella, especially if the mother is seronegative. Early delivery, delivery before 28 weeks gestation also renders a baby susceptible because transplantation transfer of immunoglobulin G antibodies occurs after this time. Risk factors for severe varicella in adolescents and adults. Thyroid therapy. High doses for 2 weeks or more are definite risk factors for severe disease. Even short-term therapy at this dose, immediately preceding or during the incubation period of varicella, can cause severe or fatal varicella. Malignancy. All children with cancer have an increased risk for severe varicella. The risk is highest for children with leukemia. Pregnancy. Pregnant women have high risk of severe varicella, especially pneumonia. Epidemiology. Varicella affects nearly all children worldwide who do not have immunity. Annual incidence is estimated at 80 to 90 million cases. The epidemiology of varicella differs between countries with temperate climates and those with tropical climates. In most countries with temperate climates, more than 90% of persons are infected by adolescents, but in countries with tropical climates, a higher proportion of infections are acquired at older ages, which result in higher susceptibility among adults. Age. The maximum incidence of varicella in unvaccinated population is in children aged 1 to 6 years. In tropical climates, varicella is more common in older children. Varicella does not have a racial predilection or a sex predilection. Children with chickenpox should avoid non-immune pregnant women, unimmunized young infants, and others with immunodeficiency or who are taking prednisone long term. Children with chickenpox may not return to school or daycare until all lesions are crusted over. Parents should take children to the hospital if the following symptoms occur: unusual redness, swelling or pain over on an area of the rash, refusal to drink fluids, complaints of severe headache, stiff neck and or back pain, frequent vomiting. The following are the most common presenting symptoms of varicella: low-grade fever preceding skin manifestation by 1-2 days, complaints of abdominal pain by some children, pleomorphic rash, usually starting off the head and trunk and spreading to the rest of the body. Typically complain of intense pruritus, headache, malaise, anorexia, cough and coryza of throat. Children with eczema or dermatitis may have severe skin manifestation during varicella. Ask parents whether their child had chickenpox previously. Recently, the validity of reported varicella history as a marker for immunity among unvaccinated individuals has come into question. Rash and fever are the typical finding during physical examination in pediatric patients with varicella. Each lesion starts as a red macula and passes through stages of papule, vesicle, pustule, and crust. Vesicles may occur on mucous membranes and break down to form shoal after ulcers. Vesicles can be hemorrhagic. Redness or swelling around a lesion should lead to susception of bacterial superinfection. The hallmark of the disease is the simultaneous presence of different stages of the rash. Fever is usually low grade. In otherwise healthy children, fever typically subsides within 4 days. Pneumonia. Perhaps the most serious complication of varicella is viral pneumonia, which primarily occurs in older children and adults. Respiratory symptoms usually appear 3 to 4 days after the rash. The pneumonia may be unresponsive to antiviral therapy and may lead to death. Varicella may predispose patient to secondary bacterial infections, rapidly spreading cellulitis, septicemia, and other serious infections may occur. The most common infectious organisms are group A streptococci and Staphylococcus aureus. Varicella places the patient at high risk for acquiring invasive group A streptococcal disease, such as the bacteremia, osteomyelitis, gangrene, arthritis, and meningitis in patients with varicella. Neurological complication. Acute post-infectious cerebellar ataxia is the most common neurological complication with an incidence of 1 case per 4,000 patients with varicella. Ataxia and sudden onset that usually occurs 2 to 3 weeks after the onset of viremia. Herpes zoster is a secondary endogenous opportunistic infection. The condition of the occurrence is transferred chickenpox, possibly in the form of asymptomatic infection. Herpes zoster acute, a cyclical disease with severe intoxication, enlargement of regional lymph nodes, often with catarrhal symptoms in the upper respiratory tract. A distinctive feature is unilateral vesicle rashes in the area of several adjacent dermatomes on the trunk and limbs and one of the face. Pediatrics condition that should be considered in the diagnosis of pediatric varicella include the following: drug reactions, insect bites, measles, meningococcemia, other common viral exanthems, for example, Coxsackie viruses, echoviruses, papilla urticaria, dermatitis herpetiformis, eczema. Now you can see differential diagnosis with acne newborn, neonatal pustulosis, children acropustulosis. Children acropustulosis is a benign disease, usually lasting longer than was a benign skin lesion in newborns. The etiology is unknown. Now you can see enterovirus exanthema, herpes labialis, and herpes zoster on face, herpes zoster, and enterovirus exanthema. Pediatrics chickenpox workup approach considerations. In general, laboratory studies are unnecessary for diagnosis because varicella is clinically obvious. However, some tests and procedures may be helpful in confirming the diagnosis or identifying complications. Most children with varicella have leukopenia followed by leukocytosis. Marked leukocytosis may indicate a secondary bacterial infection, but is not a dependable sign. Treatment approaches include supportive measures, antiviral therapy, administration of varicella zoster immune globulin, and management of secondary bacterial infections. Acyclovir is an antiviral agent that acts by inhibiting a herpes virus DNA polymerase and terminating viral replication. It reduces the number of lesions and duration of fever if it is started within 24 hours of rash appearance. Ibuprofen and diphenhydramine is an antihistamine that has a sedating effect and is effective for pruritus. Suspect secondary infection if systematic manifestations do not improve in 3 to 4 days, the fever return of worsens or the child's condition deteriorates after initial improvement. Suspicion of secondary bacterial infection should prompt early institution of empirical antibiotic therapy. Varicella vaccine consists of live attenuated oca strain varicella virus. The vaccine is safe and highly immunogenic. And varicella vaccine is recommended after each year. A single dose provides protection to approximately 85% of recipients. Now you can see the schedule of India. Monovalent varicella vaccine available in India currently are as Varilrix, Nexvix, Pox, and other. And in conclusion, key points about chickenpox. Chickenpox is a common childhood illness. It is easily spread to others. There is a vaccine available to prevent chickenpox. Symptoms are usually mild in children. They may be life-threatening to adults and people of any age with weak immune systems. The rash of chickenpox is unique and the diagnosis can usually be made on the appearance of the rash and a history of exposure. Treatment helps reduce fever and itchiness of rash. Children with chickenpox should never be given aspirin. Now our lesson is finished.